It is a huge honor today to be podcast interviewing my Stewie, Dr. Stewart Rosenberg. It's so funny because so many dentists ask me, they go, how do you release one of these every day? And it's like, I just came home from work for lunch. I'm home for an hour. Every single day, I get to go to lunch with a buddy. You've been my buddy for
Long time.
probably almost 30 years.
Yeah.
I
Yeah.
think I've actually lectured on more programs with you than probably anybody in dentistry. I mean,
Same here. Well, we did like 100 a year for like almost 3 years,
oh my God, we lived in airplanes.
didn't we? A
Just
lot of funny memories, though, for sure.
just in case there's one person left on Earth who doesn't know who you are,
I'm sure
Dr.
there are
Stewart.
more than one, for sure.
What's that?
I'm sure there are a hell of a lot more than one.
There's two. For the two people, one's in Nepal and one's in China. Dr. Stewart Rosenberg is a world-renowned innovator and pioneer in the use of lasers in dentistry since 1985, as well as in minimally invasive dentistry, microabrasion, intraoral cameras, composite dentistry, and many other dental technologies and materials. He is a founder, diplomat, and past president of the Academy of Laser Dentistry, founder and diplomat of the World Clinical Laser Institute, and a board of director, member, founder, past president, diplomat of the World Congress of Minimally Invasive Dentistry, fellow of the Academy of General Dentistry, Society of Laser Applications, Society of Laser Surgery and Medicine, American Academy of Cosmetic Dentistry, and many other national and international organizations. He has been voted Clinician of the Year and winner of the Distinguished Service Award of numerous organizations. In addition to private practice, one rated annually #1 in the United States, he lectures on a weekly basis throughout the world on laser dentistry, is on the editorial boards of numerous journals. He is a founder and co-director of RKN Seminars and has trained many hundreds of dentists in the use of lasers. He has been selected by Dentistry Today as a top clinician in dental education for 12 years in a row. And more than all of that, he is just an amazing man. How are you doing, Stewie?
I'm doing great, man. It's been too long. I miss you.
Oh, I miss you. Well, I just ran into you and we were lecturing in Greater New York. We were at a bar in that overlooked time.
Bill got us on the cell phone together.
Oh, was that on the cell phone?
Yeah, it was on the cell phone from the bar at the Marriott.
Well, you know, it's funny. The reason we called you is because we remembered like a decade before when we were on the Times Square monitor where a company got us to do a commercial during the Greater New York. And I had taken my 4 boys there and stayed in that hotel because it overlooked Times Square. It's a Times Square Marriott or whatever.
Right, yeah.
And the boys just thought it was so cool. They were like 4, 6, 8, and 10 that Dad was up on this big old. Yeah.
So cool.
And so I brought Ryan. He was home from college, and so I took him with me, and we stayed at that hotel, and that was just so fun. So we'll start. I mean, you've done so many technologies. I remember when you were out in the forefront of what was new, the intraoral camera. I remember when I got to school in '87.
Yeah.
Patterson was the only one who sold it. It was like 38 grand. It was the size of a refrigerator.
Right. Welsh Allen.
What was it?
It was Welsh Allen's cameras.
Yeah.
Distributing. Yeah.
Was it Omnicam?
I don't even remember the name. I lectured for so many camera companies. Which one was which?
And then we were on. I saw you lecture several times on microabrasion, which I still love. And there was one by Creative. There was one. There was a little Danville microetcher.
Right.
But now, what are you lecturing on mostly now? Lasers in dentistry?
Yeah, almost exclusively lasers.
So I want to ask you. This is Dentistry Uncensored. I don't like to talk about anything that everyone agrees on. I always like to go right to the point.
Of course.
Tell me if you agree with my thinking or not on this.
Okay.
I think sealants are a failed ideology. It seems like every single time I'm on PubMed or NIDR or any research, I just keep seeing that 40% fail the first year, probably another 40% fail the second year. None of them last 3 years. When you talk to individual dentists, they have no research. They have no recall protocol. They always say, oh, my implants last because I use the rubber dam and I do it right. Seems to me that the pits and fissures are filled with all kinds of organic debris and plaque. So you're taking technology where you acid etch enamel, but you're not acid etching enamel. You're acid etching Oreo cookies and crud and debris and bacteria. And then you paint this sealant on the surface where it's in occlusion and chewing it off. And it seems like the reason I'm excited about hard tissue lasers for, I'm just going to focus on what I think is the most no-brainer. A pediatric dentist, where no shots, no drill. If you were taking a hard tissue pediatric laser, or if you just took a coarse diamond, disposable, single use,
Sure.
and cleaned out those, now you're on dentin. Now you're taking acid etch on dentin and enamel where it was designed to be. Then you're basically building an occlusal composite, which technically could be called a preventive resin restoration, even though I've never cleaned out pits and fissures that didn't have crap going all the way to the dentin.
No question.
So true. Do you agree with what I just said? That
yeah, absolutely. We've known for years that sealants don't work. Resin sealants don't work. Graham Milicic in New Zealand did incredible research on this many years ago, and we used to lecture on it. The best way to do sealants, first of all, you've got to seal them almost before the teeth come in the mouth, because by the time they're fully erupted, there's usually decay and dentin. A lot of research has showed that. And we seal them with glass ionomer. I mean, we'll open the groove, check it with a diagonodent, open the groove with either a laser, or if you have a burr, if you want to use a burr, you can do it with a burr. Make sure there's nothing else in there, and we seal them with glass ionomer. And we're having much better success that way than when we used composite resin. I mean, it just doesn't work, especially because most of the time we're sealing over decay.
So I go into pediatric dental offices and I look at the schedule, and it's like, no charge, repair, chip sealant, then an hour later, repair, chip, no charge. And I'm like, why are you doing all these $27 sealants that the research says are junk? And then I go in your office, and 4 or 5 times a day, you're repairing one with the same crappy technique for no charge. Why wouldn't they do an occlusal composite?
Good question. They should be doing an occlusal composite.
And how many sealants would have to be an occlusal composite before it made sense to buy a hard tissue laser? Or would you just go a disposable diamond?
For that, I mean, well, it's a double question. As far as sealants are concerned, you can do it with a burr, you can do it with air abrasion, you can do it with whatever you want. I would not recommend buying a hard tissue laser just to remove sealants or do occlusal composites. That's not where the value in the laser is. I mean, if you have a laser, absolutely, you're going to do every one of them with the laser because it's totally painless and you're doubling your bond strength. But, and it's a wow experience for patients. I would never in a million years refer any patient to a pedodontist who didn't have a hard tissue laser. Why subject a kid to needles and drills and maybe make a dental phobic out of them for the rest of their young lives, if not their total lives, when it can be a pleasant experience instead? There's so many applications, it's unbelievable. But that said, for the average dentist, I think if they're buying a hard tissue laser in order to replace needles and drills, they're missing the value in the laser. It doesn't mean that that's not the cherry on top of the whipped cream, and it certainly has value from a wow experience, but nobody got rich doing occlusal composites with a laser rather than doing them with needles and drills. The value in lasers, and for the life of me, you know that I speak from the heart. I don't pull punches, and I think the reason why we love each other, we're both politically incorrect, because we don't give a damn what anybody thinks. We say what we know. We believe in our heart is true. And for the life of me, I cannot understand why every single dental office in the world doesn't have a laser. If you're anything but an orthodontist, you should have a hard tissue laser without question. And my personal bias, as you know, is a Waterlase by BioLase. But you should have one, whatever you choose. And if you're an orthodontist, you should have a diode laser for all the things you can do with diodes, which we can discuss in detail. And if you practice in a state where hygienists are legally allowed to use a laser, and every hygiene room doesn't have a diode laser in it, you're a freaking idiot, because you're just throwing away money. And in addition to that, you are not doing your patients the best treatment that you can give them. It's a win-win for everybody. It boggles my mind why so many offices still don't understand this. Give you a case in point. Let's just talk hygiene, okay? Because that's simple. That's something mostly everybody on Dental Town can identify with. One of the things we do on all our hygiene patients is offer them laser bacterial reduction. Laser bacterial reduction means going into the pocket with a soft tissue laser, preferably a diode. You could use an Nd:YAG, but diode is the least expensive, and there's a million of them on the market, and they all work, is to go in with a soft tissue laser with the tip uninitiated, meaning that you're not going to be cutting anything, you're going to be killing bacteria, and do what we call laser bacterial reduction. It takes maybe 5 minutes at the most with the slowest hygienist in the world to do this before she goes in with her normal hygiene instruments. The idea being to kill as much of the bacterium biofilm as possible before you go in with hygiene instruments and introduce bacteria into the bloodstream, the typical transient bacteremia, which unfortunately in today's world with so many antibiotic-resistant bacteria can cause serious problems in patients. Countries like Finland, for example, where patients can buy antibiotics over the counter without a prescription. Mom goes into the drugstore to buy a pack of cigarettes and remembers Johnny was coughing last night and says, "Oh, give me a pack of Marlboros and give me a couple of those penicillin tablets so that I can get rid of Johnny's cough." And she gives him 2 or 3 penicillin tablets and causes a worse infection, as we know. And there are people that actually have gotten deathly ill, and there's actually been reported deaths from having their teeth cleaned. So what we recommend to our patients is, in order to avoid the chance of introducing antibiotic-resistant bacteria into the bloodstream, they allow us to do a laser bacterial reduction. We charge $35 for it. We have not had, I don't think I've had 2 patients say no out of the thousands that we've done. They appreciate it. They love it. The hygienists appreciate it. So
is there an insurance code for that?
No, there isn't. You can the patient can either pay it out of pocket, or you can do what we did with oral cancer screening and just up our hygiene fee and give it to them for free. We had a thing, this is another interesting, it's not on the topic of lasers, but when I first got a Velscope to do oral cancer screening, we were charging $25 per patient once a year to have the screening done. We'd have maybe 30% of our patients agree to have the oral cancer screening when they found out it wasn't covered by insurance. They wouldn't dream of getting a pap smear when they go to the gynecologist, and there are twice as many deaths a year from oral cancer as there is from cervical cancer. And yet patients say, "Oh, it's not covered by insurance, I don't want it." So it really bothered me, because I thought it was so important that they get it, that what we did was raise our hygiene fee $50 and give it to them for free. So now they get an oral cancer screening once a year, and we get an extra $100 of what we had before, and give it to them for free. And that's what I would recommend doing with laser bacterial reduction if you're bent that way. I'm
trying to guesstimate what thousands of dentists are questioning as they're driving to work right now. Most people are driving to work. A lot of them are thinking, "Stewie, don't you have to have a LANAP for that? I thought only LANAP lasers were for bacterial reduction, and that thing's $85,000.
It's absolute unadulterated hogwash. You can't do anything with a Millennium laser that you can't do with a hot paper clip and a Bunsen burner. You can do the same procedure with any soft tissue laser. You can do it with a $2,500 diode. You don't have to spend $85,000 for LANAP. It's a bunch of crap. It doesn't mean that it doesn't work. It does. But think for a minute what you're doing with any soft tissue laser only. You're killing off bacteria and biofilm, which is critical and it's important, and you're removing the diseased sulcular epithelial lining from the inside of the flap, which is also critical and important to success in the periodontal pocket. That's all you're doing. So do you need an $85,000 laser plus another $30-some thousand in training to do that? It's ridiculous. You can do it with a $2,500 diode. Now, you can do even better period and more predictable pocket reduction and bone regeneration using an all-tissue laser that not only does what I just said for the soft tissue, but in addition, for example, BioLase with their radial firing tips, we also address the hard tissue as well while we're in the pocket. So if I'm treating the patient, and a hygienist normally can't use this, they can only use the diodes, and that's enough in the 4 and 5 millimeter pockets. But when the pockets get deeper, after they do their scaling and root planing, we bring the patient to us, and we do what we call laser-assisted scaling and root planing, which is our perio procedure. It's called Repair by BioLase. It's called LANAP by Millennium. It's called probably something else by the other companies, but it's essentially the same procedure. The difference when we're using an all-tissue laser, hard tissue laser, is we're addressing the hard tissue, which is the other part of the periodontal problem. We're removing the 20% of the calculus that the best hygienist leaves on the teeth on her best day, and you don't even have to know it there, just running the laser in the pocket, up and down in a zigzag fashion, up and down, in and out of the pocket, you'll see visually, all this black crud flying out of the pocket. Calculus and granulation tissue, and you keep lasing until no more stuff comes out. In addition to that, we're also removing the smear layer on the root surface that's put on by our conventional hygiene instruments. When you use conventional hygiene instruments, you create a smear layer on the cementum, just like we create a smear layer on dentin with a burr when we cut a cavity prep. So what the laser does is remove the smear layer, remove the endotoxins, and very lightly and atraumatically etch the root surface for reattachment. We know for many, many years that a cementum surface has to be lightly etched, lightly roughened for osteoblasts and fibroblasts to attach. They won't attach to a totally smooth surface. So in the old days, periodontists used to use citric acid or tetracycline until we found tetracycline actually inhibits reattachment for anywhere from a week to a month. So the laser will do all that. And the other thing it does that a lot of people forget about, what's the biggest complaint that patients have when they have periodontal surgery? Their damn teeth are sensitive to cold for the rest of their lives from whatever recession they get. And I was fine till you sent me to that guy. Now I can't eat ice cream, I can't drink a cold soda, or blah, 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 blah. How many times do we hear that? Forever. Well, the erbium lasers will desensitize permanently that root surface without even trying to, just as a natural part of the process. You're desensitizing the root surface at the same time. So patients will never complain of post-op sensitivity to root surfaces. It's the biggest no-brainer in dentistry. So if you're talking just perio alone, if a patient is a healthy mouth patient, $35 for the mouth for laser bacterial reduction. If they have 4 and 5 millimeter pockets, the hygienist does laser-assisted scaling and root planing using the diode laser, in addition to her regular instruments, hand instruments, piezoelectrics, cavitrons, whatever she uses. And typically, offices charge anywhere from $25 to $50 extra per quadrant, using the same code as you normally use for scaling and root planing. But you just up the fee, 25 or $50 a quadrant. So say you do $50 a quadrant like we do, that's $200 extra per mouth that you're getting for scaling and root planing. Add up the dollars in that. Now, if the pockets are deeper, or they have redundant pockets after they see the hygienist for scaling and root planing, they still have a couple of furcation involvements that are bleeding, or they have deep pockets in the molar area or whatever, or they have generalized severe perio, then they go to me. And I do what we call with BioLase the repair protocol that Larry Noren and Sylvia Kowalski and I invented, developed, and then refined over the years. And we have a lot of research that we did in Vienna, Austria, to back this up. This is not just me talking. We've got hard research in addition to tens of thousands of cases. But they go to us. We use the laser in addition to conventional hygiene. We do our procedure. I can normally do an entire mouth in an hour to an hour and a half. So depending on how severe it is, how long I have to be in pockets, or how tough the patient is to work on, or how much I have to numb, or how much I can do with topical anesthetic, it's an hour to an hour and a half. I get $850 to $1,000 a quadrant. $850 if it's 3 teeth or less, $1,000 a quadrant if it's 4 teeth or more. Not bad for an hour and a half with no lab fee, is it? And you can read a book while you're doing it. That's how easy it is. So if the average general practice has one patient like this a month, just one, That's $3,000 to $4,000 for that one hour patient of 4 millimeter or greater pockets that are bleeding. The average hard tissue laser, biolasers now, the water laser, I think the package is about $1,200 a month or something over 5 years. I don't know what the others cost. Doctors would have to ask whichever they're interested in. But biolaser about $1,200 a month. So if you get $3,000 to $4,000 from doing one hour patient, that pays your laser thing for the month plus a couple thousand profit on one hour patient. What don't people understand? This is the biggest no-brainer in dentistry. And in doing so, we've cut down on the amount of osseous surgery and bone graft we need on our patients by pretty darn close to 90%. I'm zipping up, I swear to God, I've been doing it for years, 6, 7, 8, 9, 10 millimeter pockets without surgery on a routine basis. Does it work on every site? No, there's always a few, that they're exception to the rule, and those we do osseous surgery and bone graft with. But we do that with a laser also, and that's easier than doing a class 2 composite by a long shot. And we teach doctors how to do it in our training courses. We have one coming up last weekend, third weekend in January in Irvine, for biolaser owners who haven't had advanced training yet. And that's just one of 100 different procedures we do with the lasers. It's mind-boggling.
And what's amazing is when I first started hearing this from you, how many years ago was that?
Long time ago. It's when you spelled laser, Laser.
And at that time, the periodontists, back in the late 80s, they were saying, this guy's crazy. No way.
Of course.
And now the periodontists in my backyard are starting to use lasers. I mean, they were late. They were very late to the party.
No question about it. And the only reason they're in the party now is because they're losing so many patients to people like me. Otherwise, they still wouldn't be. It's not because they wanted to change. It's because they felt they have to change if they're going to keep market share. And rightfully so. I would never refer to a periodontist who didn't have a laser.
So you're saying the water lace is an erbium laser that works on soft tissue and hard tissue, and you're calling it an all-tissue laser?
Right, because it's more than a hard tissue laser. The erbium YAGs, good as they are on hard tissue, are normally not quite as good on soft tissue as, say, a diode or an ND-YAG. And that's why most of the companies that market or sell erbium YAGs also bundle it with either an ND-YAG or a diode with it because it cuts soft tissue a little quicker and more effectively and it coagulates better. The water laser, I was amazed to find, it's far and away, I've had every laser there is. I've had as many as 12 lasers in my office at one time. It's the best soft tissue laser I've ever seen on this earth, period. It cuts the best. It doesn't cause any scarring. It doesn't cause any charring or delayed healing or adjacent tissue damage. It's the best soft tissue laser, and in my opinion, also the best hard tissue laser.
So, Stewie, what happened to the carbon dioxide lasers? Because back in the day, that was going to be
that was my baby. I helped bring it into dentistry, and along with Bob Pick and a few others, Stu Colton, there were 8 of us, we wrote the manual on how to use it in dentistry. Actually, in Phoenix, Arizona, we went to the Point Resort at Tapa, whatever it is, Cliffs.
Yeah, I live 3 miles from the Point.
Yeah, well, we sat around a conference table and hammered out very scientifically the manual on how to use a carbon dioxide dentistry by saying, what are you doing with it? Well, I'm doing frenectomies. Well, what setting are you using? I'm using so-and-so. Well, how about you? I'm using such and such. All right, can we agree that let's go between the two, and that's our number for frenectomies? I mean, that's literally how we did it. And then we also founded the Academy of Laser Dentistry at that meeting. So it was really a landmark meeting for laser.
So what was wrong with the carbon dioxide laser? Why did it get replaced?
It died because it was, number one, it was strictly soft tissue. The big advantage to carbon dioxide in the old days was it cut soft tissue faster than the other soft tissue options, which were ND-YAG and argon. However, every patient had to be numb. There was postoperative discomfort. And most importantly, it died because you really couldn't use it in a periodontal pocket. It didn't, whereas the other lasers work on solid glass fibers or tips, so you can make them small enough to get into a periodontal pocket, CO2 energy has to be funneled through a hollow tube. And no matter how small you make the tube, if you put it in a pocket, if it's small enough to get in the pocket, the minute you get a little bit of granulation tissue clogging up the tube, you got to throw it away, end of story. So it's virtually impossible to do perio with it unless you lay open a flap and do it that way. And it's not good on hard tissue, so it kind of died. And I haven't used one in, gosh, almost 15 years.
How come when you do your laser training course, you should digitize one of those and film it and put on Dental Town? Stewie, we put up 350 one-hour courses, and they've been viewed over 500,000 times. You should get some of those laser guys yourself, someone you should put one of those on Dental Town. I mean, if you're already teaching the course.
I will. I'll do it. You know, I lecture every week. I mean, it's easy to do.
I know. Why don't you film one of those?
I'll do it. How long should they be?
Well, that is on, they like their AGD credits, so they're usually in increments of hours. Most of them are 1 hour, some are 2 hours, a few are 3. Carl Misch, his was 4, but it depends on the deal. But I mean, I think the more the merrier, because
great. I will try and record the highlights of my normal one-day lecture and get it to you. Because people really need to know about this. It is such a no-brainer for every office. You talk about recession-proofing practices. I mean, I don't know how it is in Arizona, but everywhere I talk to dentists, people are still not where they were in the salad days. We got holes in our appointment books. We got hygiene patients that don't show or cancel last minute. It's not what it used to be. And in my office, I'm in a lower middle class to middle class area, halfway between Baltimore and Washington. A lot of people who are on PPOs and HMOs and whatnot, and or work for big corporations, and a lot of or for the government, and they're hurting, and they're still hurting. It's maybe starting to come back a little bit, but it's not where it was back in our salad days. And in my lifetime, I don't know that it'll ever be. I don't know how much longer I got. I'm 75 now, and I'm still doing it because I love it to death. But one day the traffic will start to bother me, and I'll say the hell with it. But we have as many openings in our appointment book as anybody has, more than I've ever had. In May, June will be 50 years in private practice.
Congratulations, buddy. Seriously, so you graduated when you're, what, 24?
66. I graduated in 1966.
And how old were you in 66?
I don't know. I'll be 75 in March, so what's that?
So you're 25?
I guess 24, 25, something.
And you're celebrating your 50-year anniversary?
Yeah, June, we're having our 50th reunion.
Oh, my God. Send me pictures. I want to put them in Downtown Magazine. I mean, that is just epic, man. Congratulations on an epic career.
Amazingly, some of us are still practicing. And none of us because we have to. All of us because we love it too much. And I don't want to ever stop because I'm enjoying it too much. And I mostly enjoy changing lifestyles and teaching dentists how to improve their practice and their wealth and everything else with lasers and other stuff. I
want to sum you up from how I've seen you. I've only seen you for half of those 50 years. I've known you since the late 80s.
Right. Yeah.
But if you look at all your background, I mean, it's lasers, but it's minimally invasive dentistry. It's micro air abrasion. I mean, basically, I'd sum up Stewie is what you've done for me and so many people listening to you is you don't like to shove a tooth and a pencil sharpener to do a crown. You like to save tooth structure. You don't like flapping tissue back and putting a bunch of stuff.
Absolutely.
You always try to touch the patient the least to get your dental cure medical outcome. Is that a fair summary?
Yeah, absolutely. And I know you're the same way.
Yeah.
And that's the way it should be. That's the way it should be.
I think of the.
It's easy to do. It just takes education and a commitment.
And that's neat because I mean, when I was listening to you, I mean, you were a big teaching me into, show the intro camera. These people don't know what an MO and a DO. Show them the black hole. Then take air abrasion, clean that out. No shot, no drill. You didn't make it dental phobic. You didn't hurt them. They're not numb. And then show them with the intro camera. Then fill that. I mean, exactly. You've always been, you've just been a hell of a guy. Don't touch them. Don't hurt them. Get rid of the disease with as few shots and reducing tooth structure as you can.
That sums it up. That's exactly what I believe in.
And then you go to the next seminar lecturing in the room next to you, and it's some practice management person talking about crown opportunities, and every time someone comes in, you should be pointing to an MOD, and there's a crown opportunity. You should be doing 4, 5, 6, 8 crowns a day, and it's just like,
Right.
man, who wants to be? I mean, you didn't go to dental school to shove 8 teeth a day into a pencil sharpener.
Agreed. Agreed 100%.
Yeah.
So many teeth, if people are condemning to crowns, would be just as well off with indirect or direct restorations, whether it be a ceramic inlay or onlay or a direct composite that don't need crowns. And not that we don't do a lot of crowns. Sometimes you don't have an option.
Well,
but,
I was in,
but you don't always just condemn every tooth to a crown if it doesn't need it.
I mean, I was in a dental office yesterday, and this patient had a large abfraction. So you know what the dentist did? Crowned it. So to treat the wear from the abfraction, you stuck the whole tooth in a pencil sharpener. People will have worn down teeth. So what do? How do they treat the worn dentition? They stick all the teeth in a pencil sharpener and build them up with PFMs.
It's criminal.
Yeah, and then and endo is the funniest. You'll see someone with a root canal on an incisor, but every root canal needs a crown. So then they'll file that down, and by the time you file an incisor down
right,
for
it's
a crown,
and then you're going to do an implant.
I know. So yeah, so you've probably saved 50 tons of enamel in your 50 career years as a dentist.
I hope so. At least I try to. But you got to do what's going to be in the best interest of the patients, and sometimes you have to do macro dentistry, but not any more than we absolutely have to.
So I'm going to follow on that thread. Is what happened to air abrasion?
Air abrasion kind of died out, I think, because of the mess of the powder.
Right, I know. My assistant Jan's. I mean, every time I get that thing out, she gives me the eye.
That's what happened. It was the mess of the powder, and now with the hard tissue lasers, you don't need it anymore. I still have one. I rarely ever use it. I use it more to clean out the insides of veneers and ceramic crowns or whatever to rebond them than I do to do dentistry with, because I use the laser for it. It's just easier for me to do them without the mess of the powder. But air abrasion certainly still has its place in many areas, and for sure was revolutionary when you and I started promoting it. And
is anybody still selling it?
I don't know. I don't know if anybody is anymore. I don't know who is, if anybody.
Danville sells the micro.
Yeah, I think that may be about it. I got a funny story to tell the audience about air abrasion when you and I first became friends. Can I tell that story?
Sure.
For those of you listening, Howard vilified me on lasers, which he knew nothing about at the time. He spelled it Lazer. And we had never met, but we kind of hated each other, even though we'd never met. And then I'm doing a seminar, I think it was the American Academy of Cosmetic Dentistry meeting or something, on air abrasion. And Howard's sitting in the back of the room, and I see him, and he sees me, but we don't say anything then, either one of us. And then he comes up to me at the end of the program. It's the first time we'd actually ever physically met. And you said, "This is really interesting. Can you tell me more about air abrasion?" And I was dumbfounded. I said, "I'll tell you what I'm going to do." I said, "I'm going to fly down to Phoenix personally and bring an air abrasion unit into your office and show you how to use it and tell you all about it. And all the promise I want for you is if you try it. And if you like it, you'll buy it. And if not, send it back. No harm, no foul. At least I did my best." And you said to me, "Well, why would you do that to me?" And I said, because right or wrong, and neither of us are always right, neither of us are always wrong, but the one thing I've always loved about and respected you for was your passion for dentistry and doing what you honestly believe in. And I know that if you find, and hopefully you will, that you like it, you will be evangelistic, and more people will start doing minimally invasive dentistry because of your passion and the way you promote things you believe in. So I bring me and the rep come down to Phoenix, Arizona. I bring the unit in. I do a slide presentation. The whole staff is there. Everybody's there. Howard's in and out of the room 87 times, answering phones, doing this, doing that. And we leave thinking that son of a bitch didn't even listen to one word I said. I was livid. I get a call a few days later. I did like 9 restorations yesterday and 10 today or whatever. I flat out love this thing. What can we do to promote this? Why don't we lecture together and spread the word around the world? I said, Howard, deal. And that's how we became friends. And then we lectured literally, I think, 100 cities a year for 3 years in a row. Everywhere we went, having a ball, me in the morning, Howard in the afternoon, and just loving it, and hopefully doing dentistry some good by promoting minimally invasive dentistry. And that's how we became friends. It was May, remember?
I do remember. God, it was so long ago. And the other thing I think about that is I think of all those lectures where it seems like half the room it was just dentists saving money coming by themselves.
Right.
And then the other half of the room would be one dentist with 5 staff members. So the left side of the room would maybe be 200 dentists, and the right side might only be 10, but 100 staff.
Right.
And it was the dentist who always brought all their staff. That always got to implement. If you got the staff behind it, it got implemented. It got done.
Absolutely, like with everything else.
I know. And then you go look at the income of the dentists who brought all their staff, and they were making twice as much money as the dentists on the other side, all saving money, not bringing their staff. They never got that it was a team sport.
And it's never changed. It's the same way now as it always was.
Okay, I want to ask you another thing. This is Dentistry Uncensored. I want to ask you. I'm going to throw my own country under a bus. How come when I go around the world, the Americans use the least amount of glass ionomer, but as you get closer to Japan, Australia, New Zealand, they use glass ionomer? Why is there that shit? Who's right, Japan or the United States? Is it Australia,
Japan,
New Zealand?
I think Japan and Australia and New Zealand are right.
Okay, so and that's
how I got involved with it. Graham Milicic from New Zealand made a believer out of me back in the early days of the World Congress of Minimally Invasive Dentistry when he did a program on the use of glass ionomer as a sandwich technique in Class 2 composites.
Okay, you're going to have to explain sandwich technique.
Yeah, well,
okay.
When we use a composite in a proximal box, if you can envision from dental school how the enamel rods lay in a tooth, and how the dental tubules lay in a tooth, you will see that at the bottom of a proximal box, they're laying on their side. So there's virtually, if not literally, no bond strength to the bottom of a proximal box in a Class 2 composite. Virtually none. Because you need mechanical retention, and you're trying to get retention. It's like spitting on the side of the wall and getting something to stick. It's not going to do it. So where do Class 2 composites fail most of the time? In the proximal boxes. Recurrent decay in the proximal boxes because of lack of proper bond strength. Glass ionomer, in addition to the constant fluoride release, also is a chemical bond, an unbreakable chemical bond to dentin. You can break the composite, you can break the glass ionomer, you cannot break the bond between the glass ionomer and the composite. And the glass ionomer and the dentin. Ian No from Australia, you know Ian.
Oh yeah,
brilliant guy.
I flew him to my study club right here in Ahwatukee 20 years ago.
Well, then you know what he's talking. He's saying exactly what I'm just saying, and he did incredible SEMs to show that. So the best way, in my opinion,
he was in Adelaide, wasn't he? Adelaide, right. Australia, originally from Vietnam.
Exactly. He went from Vietnam. He was a Vietnam boat person with his family. They went to New York, somewhere in the States, and then somehow emigrated to Australia. So this is a Vietnamese Australian who speaks with a New York Vietnamese Australian accent.
God, I love
him. Great guy,
yeah.
Brilliant. So they made a believer out of me with glass ionomer, and it was Graham's work that showed me the fallacy of composite sealants and why we should be using glass ionomer sealants. Preferably something like Fuji Triage, which has 7 times or 6 times the fluoride release of like Fuji 9 or Relax or any of the other, glass ionomers. So I agree 100% that we're doing it wrong. I really believe that. Can
I tell you why I think what the difference is? If I had to explain it, what is the difference? I think U.S. dentists are engineers and Japanese, Australian, New Zealand's are biologists, and whenever you talk to an American, like their gurus, like Gordon Christian, he'll talk all day long about the wear rates, the bond strings, it's building a house or a bridge. And then in Australia, New Zealand, and Japan, they always think, okay, I don't care how you build your barn in the backyard, it's going to get eaten by termites. It's a dentistry is a biology problem. It's bugs eating teeth, bugs eating gums, and they always are trying to build a restoration that continues to have some type of effect on the biological life forms. Is that a fair summary?
I agree 100%. Could not agree more.
And there's a U.S. company that's kind of got it. What is it? Pulp Dent?
Yeah.
Pulp Dent.
GC America does too.
Well, GC America, that's the GC's out of Japan.
Yeah.
Yeah.
Yeah. So I mean, they get it also.
And I was talking to the president of Ivoclar, Bob Ganley, and I was asking him about that, and he said, yeah, Ivoclar gets it. We totally get it. The Holy Grail is trying to find something to put in these resins that kill bugs. I mean, it's like these big billion-dollar companies. I mean, they totally get it. But in the meantime, until the resin companies can build anything antibacterial, I don't think the U.S. are going to go to glass ionomer. Or do you think, or do you see it improving?
I haven't seen it improving. I really haven't. I think that we're still doing it the same way we did it 30 years ago.
So the sandwich, so you would recommend to these listeners that you think these fillings would last longer if you did an MOD composite to fill up the proximal boxes with glass ionomer, and then a sandwich is
sandwich it with
whatever you're using now.
Right. Whatever composite you're using.
Okay, so then, okay, go ahead.
Or do an indirect restoration with a universal, modified resin glass ionomer cement. That'll accomplish the same thing. And I do more indirect restorations now than I do direct, if they're of any size at all. I just think they last longer, they're better, the contacts are better, the aesthetics are better, and I don't get the marginal leakage that I was getting on complete, just composites.
What are you cementing with?
Right now, we've been using Nexus.
Nexus?
Yeah. I don't know if it's any better than the others, but
okay. So why are you using glass on? Okay, I want to get clear on the sealants. Do you think sealants are a failed ideology and should go by the side of the road?
I think resin sealants are for sure. Okay. I think glass ionomer sealants are still very valuable.
Okay, and so
depending on when they're done, the Graham Millicis used to show some amazing things, where he would show teeth that were half erupted, still had an operculum, say a lower first molar, still had the operculum over the distal half of the tooth, that had complete occlusal decay way before it ever fully erupted. And so what he recommends, and what he and No recommends, is the instant a tooth starts to erupt, you etch it and seal it, smear on like Fuji triage all over the whole occlusal surface, under the operculum and everything, and then just let the tooth erupt. What the glass ionomer does is infuse fluoride into the tooth to help prevent the enamel from decaying and the groove from decaying. And then when the tooth is fully erupted, eventually they'll wear the glass ionomer off of occlusal bearing areas once it comes into occlusion, but it'll still be in the groove, and that's the ideal best sealant as far as I know. Other than that, I would either explore the groove, check it with a Diagonodent or something similar to make sure there's no decay in the groove, and then seal it with glass ionomer also, rather than with composite. I just think it's a better restoration, and it's easier to do because you can place it in the presence of saliva or whatever in the mouth. The tooth doesn't have to even be bone dry like it does for a composite. So I mean, how hard is it for a hygienist with no assistant, no rubber dam, to do sealants that aren't contaminated? It's almost impossible.
Now, Fuji's made by GC, right?
Yeah, Fuji's made by GC, but there are other companies that make them too. But what we always used was Fuji Triage. Down in Australia, it was actually invented, I think, by he and No and Jeffrey Knight for GC, because it has something like 7 times the fluoride of regular glass ionomer, and that's why it was called Fuji 7. When it came to the United States, they changed the name to Fuji Triage. But I think that's the best one for those situations because it has a higher fluoride release. But any of them are going to be better than regular composite.
And I just want to say one of the things. you see dentists who just they literally brag to everybody that they're amalgam free. They haven't played, they're metal free, they're amalgam free, and they don't have any glass ionomer. And the fastest growing age group is senior citizens. We got tons of Alzheimer's, tons of dementia, and
Right.
you will see them bring in an Alzheimer's lady who's 80 years old and do 7 or 8 root surface decays, and they'll do them with resin composite. Stewie, what do you think of that?
Um, you're asking the wrong guy because I haven't done an amalgam in
Well, no,
about 43 years.
but I mean I'm talking about not just amalgam, but for root surface decay in nursing homes. For they got their fellowship in the Academy of Cosmetic Dentistry, and they got these highly polished resin class 5s on a grandma with root surface decay in a nursing home. And if those would have been done glass ionomer,
It would have been fine.
would
Yeah,
they have lasted longer?
I think so. I think they would have been best. It wouldn't be as aesthetic, but an 80-some-year-old woman that doesn't even know she has teeth anymore, what's the difference? You just want to preserve the teeth and make her comfortable.
And
So I would use glass
I
ionomer.
think root
Sure.
surface decay in the nursing home is an
It's rampant.
the geriatric dentists are telling me that when you're admitted to a U.S. nursing home, you're getting 1 root surface cavity per month.
I believe it because they all have dry mouth. They don't brush properly. They don't eat properly. And so it's epidemic. So I would treat all of those with glass ionomer, which gives fluoride release. It's easy to place. It's inexpensive. And I think that's the best treatment for them. I agree with you 100%. Let me get back to lasers a second because I was on track with something. Then we went off on another thing, which is great. But I wanted to mention something about recession-proofing your practice with lasers. I got as many open holes in my book today as I've ever had in almost 50 years of practice. I could come into the office on Tuesday and have an hour and a half open, 2 hours open, and I could still have a $10,000 day from what I pull out of hygiene and do in between patients during that open time with lasers. And it's everything from gummy smile reductions, which take 10 or 15 minutes at $325 a tooth with topical anesthetic, to biopsies of lesions, to you name it, to incisal edge, composite restoration. How many, you talk about senior citizens and all, how many millions of patients do we all have in our practices that have worn incisal edges that they hate, and if they bite down on a poppy seed or a popcorn kernel, they shatter off the lingual plate of enamel, and I don't know about you, I've never been able to get a composite to stay there long term. It just never seems to work in my hands. We end up eventually having to do a reverse veneer or mini crown or something. But you can use a laser to cut down into that dentin 2 or 3 millimeters. Takes about 10, 15 seconds per tooth to do. Put some composite in there. Patient gets charged for 2 surface composite, incisal-lingual or incisal-facial. You can do 6 or 8 teeth in 20 minutes, start to finish. Make your day. And then also, of course, you want to try and counsel them to the importance of you're making them a night guard so that they don't wear it down again. We do these on a regular basis. How about somebody who comes in that breaks a tooth off at or near the gingiva and need a hard and soft tissue crown lengthening because otherwise biologic width would be invaded? We can do the hard tissue crown lengthening without a flap, without any additional chair time, prep our tooth, take our impressions, send it to the lab, or if we have a CIRAC or an E4D, we do the crown lengthening while the crown's being milled, and the patient goes out of the office with their crown, same day. And we've got, they don't have to wait 6, 8, 10 weeks to get their crown. We do everything in 1 appointment, or if we're using a lab, in 2 appointments. And we get an extra $900 over and above what we charge for the build-up in crown. Why would you refer somebody to a periodontist to do that? Have them use up their insurance benefits and maybe not even be able to afford to get the crown now. And in best case, wait 4, 6, 8, 10 weeks before you can do the crown. Sit there with a hole in their mouth. And let them make $900 or $1,000 or whatever you want to charge, when in 2 minutes, literally 2 minutes, you can do it yourself. Or how about a patient, we're talking about the old class 2. Somebody had a big old class 2 amalgam. How many times we've seen with the proximal boxes at or literally below the level of the bone? Now you want to try and do a CAD-CAM onlay or even a direct composite or indirect composite. You can't get a good margin. The margin's below the bone. There's no way you can get it. But you can use a laser to recontour the bone in that spot, charge whatever you want for it, charge them for crown lengthening, be able to take a perfect impression or a digital reading, and you're home free. Or a patient comes in, they have a crown or a veneer that's gorgeous. I had a patient about 2 months ago, had 6 beautiful veneers, cuspid to cuspid, and the gingival margins around the veneers were bright red. I mean, as bright red as you can get, and you just looked at them and they bled. And the guy came into us for a hygiene visit, first visit, and my hygienist said, look at the inflammation around these veneers. And the guy said, oh, my dentist said I'm allergic to porcelain. And that's why they're inflamed, because I'm allergic to porcelain. But what can I do? I said, well, you're not allergic to porcelain. What's happened is, and I explained to him what invasion of biologic width is. So I scheduled an appointment, and in 15 minutes, we did hard tissue crown lengthenings underneath the gingiva on 6 teeth, and a week later, the tissue looked like the most gorgeous tissue you've ever seen in your life.
Okay, but I'm going to interrupt you because the periodontists tell me that only 20% of the dentists do crown lengthening and get the biological minimum width. They all tell me in every city, every country that all their patients for crown lengthening, and so they go to the other dentist. They don't refer, and they think, well, who are they referring to? Or are they doing them themselves? And they say they're not referring them to anybody else, and they're not doing them. So I want you to slow down, Spanky, and go over what is the violation of the biological minimum width? Why is crown lengthening a procedure? And explain it in a way. I mean, first of all, do you agree that 20% of dentists agree with this and do crown lengthening, and 80%
I don't know the percentage. I do know there are a lot of bad dentists out there, or dentists who just haven't been educated to do what some of the rest of us have taken continuing education and learned. I don't want to knock anybody, but that's the facts.
Okay, so you got 9 minutes to explain why 4 out of 5 dentists do not do crown lengthening, and why do I need to do crown lengthening? What is this biological minimum width? It sounds like a BMW. Are you telling me to buy a BMW?
You got it. Okay. Okay. Biologic width means you have to have 3 to 4 millimeters from the margin of your restoration to the beginning of the bone. To the beginning of the bone. If, for example, I'm going to do a gummy smile reduction because somebody's not showing enough clinical crown and I want to recontour their gingival margins, whether I do it with a laser, a scalpel, electrosurge, whatever. If once I get done and I probe from the new gingival margin to the crest of the bone, if I have less than 3 millimeters, what's going to happen? The tissue is going to rebound back to where it was because I've invaded biologic width. We need that space in order to maintain biologic width, 3 to 4 millimeters. So if we do a crown, and when we finish the crown, the margin of the crown is less than 3 millimeters to the beginning of the bone, that tissue is going to be chronically inflamed for the rest of that patient's life. We've all had patients where either we or some other dentist have done a beautiful crown. Everything about it looks good. The margins are good. The aesthetics are good. The occlusion is good. Contacts, everything's fine. And yet the darn buccal tissue and papilla bleed like crazy. No matter what they do and no matter what we do, we continue to bleed. The reason is you don't have enough space between the margin of the crown and the beginning of the bone. So what a periodontist would do in that situation would be to lay a flap, take a burr, and trim the bone back so that you then have 3 to 4 millimeters between the new height of the bone, crest of bone, and the margin of your restoration, and then sew it back up. And now you'll have to wait umpteen days or weeks before you can do your crown. Or you can take a laser, stick it in the pocket without a flap, touch the bone, back it off a millimeter, sweep it side to side for 30 seconds to a minute and a half, melting away the bone and recontouring it, and you're done. Why would you not do that? Why would you not do that? You're going to end up with a better restoration, one where the tissue's never going to be inflamed again. Patient's going to be happier, and you're going to get the going rate for whatever is charged in your area by a periodontist for hard tissue crown lengthening. In my neck of the woods, it's $900, so that's what we charge. So when I'm doing a crown, if it needs a crown lengthening, I get an extra $900 for a minute and a half of work. But I assure the patient then that we can get the crown the same day if we do a CEREC, or 2 weeks later if we're doing a lab process crown. It just makes absolute sense. Everybody should be doing it. Everybody should be doing
I
it.
want to ask you other questions. A lot of times people are lecturing, or you see an advertisement talking about low-level laser therapy.
Yeah.
What is low-level laser therapy?
Low-level laser therapy is my baby. We teach it as an integral part of our advanced training course, and it is truly magic. To use as an analogy, low-level laser, if God forbid somebody you love was in a terrible automobile accident, they're laying in the hospital, tubes running everywhere and monitors, and you go in and you're mortified, and you pray to God, please do whatever is in your power to heal him as quickly and as painlessly as possible. That's what low-level laser energy does. When we shine specific wavelengths of light delivered by the proper mechanism with BioLaser's Epic X laser, has 2 handpieces with it. One is one we use also for bleaching teeth. And the other is called a pain relief handpiece that channels the energy deeper into tissue. I treat everything from, first of all, whenever we do any surgical procedure in the mouth, regardless of what it is, we hold the bleaching wand on there. We turn the laser on to 3 watts continuous power, hold it on there for 30 seconds, and the wound site will heal 50% faster with no swelling, no pain, no nothing. If I have a sinus problem, I can open my sinuses. I treat carpal tunnel syndrome on my hygienist. I have bad knees from old lacrosse injuries, and when my knees act up, I have one at home, and I use it every day on me. There's nothing you can't use it on in the body to make it heal faster, in or out of the mouth or anywhere in the body, other than the eye. You can't use it on the eye because the wavelength will blind you. So you have to wear protective eyewear when you use a diode laser. So we couldn't use it on the eye. But anywhere else on the body, it is magical. The other really cool things I've done with it, I've closed oral antral fistulas completely in 3 or 4 sessions just using a laser, without a Caldwell lock, without anything. I had one patient that had an 8-millimeter oral antral fistula because she'd been on bisphosphonates for a rare type of cancer that made her bones so brittle she would roll over in bed and break an arm or a leg or a wrist or whatever. And she was going through chemotherapy. So she had this 8-millimeter fistula where the oral surgeon take it out an upper first molar. I completely closed it in about 25 days, with her coming in every 3 to 5 days. Completely closed it. It's unbelievable. We're also treating paresthesia very effectively. I'm so far, knock on wood, 10 for 10, reversing paresthesia. The longest one that was numb, that had out, was 3 years. Somebody had a lower third molar extracted on the lower right side, and lip was numb for 3 years. We reversed it in about 3 weeks. And I've had some where they were just numb like a week after extraction or 2 weeks after extraction, and then only 1 or 2 sessions, and they had the feeling back. So that's something that every dentist who's interested in this stuff should look into. You can use the water lasers. The erbium lasers are not good lasers for low-level laser biostimulation. You need a diode laser. The best of the bunch, because the wavelength and the delivery system is the best for this, would be biolasers. But you could do it with other lasers. I could teach you how to do it with other lasers by taking the tip off the handpiece, defocusing 5 millimeters at a lower energy, about 0.7 watts, and not get as predictable result, but still get good results with it. But it is, Howard, it's off the charts. It's off the charts. You are my hero running marathons and doing all the stuff you're doing. I know you gotta have aches and pains and bruises and stuff for sure. After all the abuse you put your body through, man, you should be using a diode on it when something bothers you. It'll be better so much quicker. It's unbelievable.
Last question. I only got you for 1 more minute. You've been talking about lasers this whole time. Laser bleaching, is that marketing hype, or does that do anything, or does it not do anything for tooth whitening?
Okay. You know my history with tooth whitening. I was in it from the beginning. And bleach is bleach. I don't care whose it is or what it is. It's all the same stuff. There's carbon peroxide and there's hydrogen peroxide, one for take-home, one for in-office. Nobody's going to get lasting results without take-home, as we all know. So what is the advantage of using the laser? Time and less sensitivity. because a laser is only on a quadrant for 15 seconds at a time. Depending on how quickly your assistant or hygienist can put on the paint on rubber dam, you're going to get faster results. We typically bleach a patient with a laser in a half hour. With our zoom light, which we also have, takes about an hour to an hour and a half. The results we're finding are pretty much identical, good or bad. You know, brown teeth and yellow teeth bleach well, green and gray teeth don't. And that's just the facts of life, and none of them work well without the take-home. So I wouldn't buy a laser just to bleach teeth with, but there is an advantage in time saving. And anecdotally only, I haven't done a study on this, the patients we've done with a laser seem to report less post-op sensitivity of their teeth after the bleaching than people we've used the zoom light on, because we don't generate as much heat, and you're only on a quadrant for 15 seconds at a time, rather than, you know, baking the teeth for an hour or so.
And one last, I'm over the hour, I got to get off, but one overtime question.
And I got a flight.
Yeah, Stewie, a lot of, you know, in business school, you know, they're saying your business has to have a unique selling proposition. What is different about you than anyone else? I just hear a lot of dentists that will tell you off the record that the best thing their laser was for marketing and advertising on their website to be a laser dentist. Do you see any of that? Do you think there's any truth to that?
There's no question about it. We get a ton of patients from our website because I'm a laser dentist. No question about it. But once they come, it's what you do with it that really matters. Once you get them in the door is one thing, and we get them in the door because we're laser dentists. That's the number one marketing thing for my practice, especially the fact that I can treat periodontal disease without having to do conventional periodontal surgeries. We get a lot of patients from that.
My podiatrist buddy is just blowing it up in podiatry because he's the only one with a laser.
Toenail fungus.
What's that?
Treating that toenail fungus.
Yeah.
Probably.
Well, hey, go
and you
catch
can
her.
do that with dental laser, by the way.
Where are you off to now?
I go to Tampa, Florida to lecture all day tomorrow for BioLase, and then tomorrow night fly to New York to lecture all day Saturday too. I'm a glutton for punishment.
You're a road warrior, but buddy, I love you to death. Really do. Thank you so much for 25-year friendship. Thank you so much for what you have personally done for me. And Stewie, you got to put an online course on Dentaltown.
I will. I promise.
Because you're old school where you fly around the world 24 hours a day. You put an online CE course on Dentaltown. People will be listening to this in China while you're sleeping.
I will. I promise I will. It's so great to reconnect. Thank you so much for inviting me.
All right, buddy.
Be well. I hope to see you soon, man.
All right. Thanks for an hour. Thanks.
Bye-bye.